Good evening, everyone. Welcome to the LASI-DAD's third webinar. It's our great pleasure to have Drs. Joyita Banerjee and Marco Angrisani. Today, they will be discussing and introducing our informant interview, which is a critical component of our protocol that allows family members to report participants' both health and cognitive status, as well as their changes over time. And one of the innovations that our team brought into the project is to think about the dementia caregiving and how dementia caregiving is provided in India by family members, and whether such caregiving put any pressures or burdens on the caregivers. So it's my great pleasure to introduce Dr. Joyita Banerjee, who has been a critical member of the investigative team from the very inception of the pilot study. So Dr. Joyita, please go ahead.
Thank you, Jungkook, and welcome everyone to this third webinar of the LASI-DAD Webinar Series. Today we will be talking about the informant interview, which is, as Jungkook said, which is an important part of the cognitive interview. So for assessing cognitive status, there can be two ways. One is the objective cognitive interview, which has been dealt by Dr. Pranali in the last webinar. And of course, the informant interview, where we ask question to a person well known to the respondent who can talk about the respondent. So going ahead, so the contents will be like this. We will be talking about the, excuse me, introduction to the informant questionnaire, the informant interview, the contents of the informant interview. Then we will go ahead with the caregiving in India study and the dementia caregiving and empirical evidence from a study published led by Marco Angrisani et al. And published in Alzheimer's and Dementia. So going ahead, who can be an informant? So in our study and also in regular cognitive studies, an informant is someone who knows the respondent well, who interacts with them on a regular basis, and therefore knows their difficulties and limitations and can report on them. During our first wave, we had a question for the respondent where we asked them who knows them the best and who can be an informant for them. During the second wave, we tried to interview this informant as much as possible during the second wave of LASI-DAD study. So what is the goal of the informant interview? To obtain detailed information about the respondent's cognitive functioning, daily activities, health, and challenges in these outcomes over time. So the interview mode is usually face-to-face, but if due to some reason, due to the scheduling or some reason where the informant is not able to give us time, we also conduct the informant interview over telephone. Now, informed consent is always obtained before starting this interview. So we obtain reports of cognitive and functional changes from someone who knows the respondent well and observes them on a regular basis. It can be a family member, say a spouse or a child or a daughter-in-law or a caregiver or a neighbor who knows the respondent very well. So what is the advantage of an informant interview? There will be no self-report bias, which we can see in the objective cognitive interviews where we ask questions directly to the respondent. This is relatively unaffected by education and culture or language. Many of the cognitive screens or the commonly used cognitive scales have been developed on a predominantly Western population and may not be correct, may not be appropriate for India, where we have less of education and there might be cultural differences or language differences. But for an informant interview, we can ask the informant about the respondent and these factors will not affect the interview. This can be compared with the respondent's performance on the cognitive. The informant's report can be compared with the respondent's performance on the cognitive tests. This can capture changes or decline in cognitive abilities and disability and with daily activities and their dependence on daily activities better than performance on cognitive tests. So, what are the contents of the informant interview? So we start with the demographics, where the informant, we start with the informant demographics. Then we ask questions on the JOM IQ code, which is a questionnaire, a popular questionnaire used for informants. We do the blessed test parts A and B, the community screening interview for dementia, CSID, the 10 by 66 brief informant report. Then we have some questions on activities that are done by the respondent. Then feelings and emotions of the respondent, questions on this, and judgment and problem solving questions. This is the flow of the informant questionnaires. Um, So the informant, overlooked this slide. The informant questionnaire actually has other things also. We have the main informant interview. And as Jinko told, in the second wave, we have the caregiving responsibilities and consequences interview. We also have a food frequency questionnaire as part of the diet initiative of the LASI-DAD study, which has questions on food consumption habits, food frequency, spices taken, Ayurvedic or herbal supplements taken. And we have also added an end of life questionnaire where we get information about the cause of death or the events leading up to the death of the respondent from the informant. We also ask a question whether the death was related to COVID or not. This is the flow of the questionnaire. So in the demographics, we ask about the different demographics of the informant, their age, their gender, their relation to the respondent, how long they have been knowing the respondent, whether they are a family member or don't stay with the respondent, how frequently they meet the respondent. All these are covered in the demographics part. The education of the informant, all these are covered in the demographics part. Then we go to the JOM IQ code, which is a very, a common questionnaire, the informant questionnaire for cognitive decline in the elderly, and which tracks the change in the respondent's functioning over the last 10 years. The blessed test type 1 and 2, which has questions on the respondent's ability to do basic activities like feeding or dressing, going to the toilet, these activities. And the part B has questions which ask whether the loss of these abilities are due to physical decline or cognitive decline or both. The community screening interview for dementia, the respondents has questions on the respondents' performance in everyday living. The 10 by 66 informant questionnaire has questions from the 10 by 66 brief report, which also has questions on the respondents' difficulty with activities of daily living. Then in activities, we have added these questions. We ask different activities that the respondent takes, like maybe reading or some hobbies, watching TV, using the computer, going out going out for walks or doing exercises like yoga. These kind of activities we have questioned on the activity section. Feelings and emotions. The questions are on respondents' feelings and emotions during a typical day. Have they been feeling upbeat? Have they been feeling happy? Are they in charge of their emotions? These kind of questions in the feeling and emotions part. We have added the judgment and problem solving questions in wave 2, where we ask some questions which deal with similarities and differences between objects and some common problem solving questions. Now, going to the next part, this was all about the informant report. Now going to the next part where that is caregiving in India. I'll give you a little background about this. Caregiving in India has a lot of different nuances, and these are all cultural nuances. So usually we are used to extended families or joint families where multi-generational people live together. That used to be a norm in India, mostly in the rural parts, where extended families played a major role in caring for the older adults in the family. These have changed with time, the passing of time. This has changed. Then the gendered roles and cultural expectations dictate the caregiving roles. Mostly the caregiving roles fall on women of the family. Mostly it is the spouse, the sons and daughter-in-laws. Usually in India, older adults, as they grow old, they stay with the son and the family. The son and daughter-in-law are the main caregivers for older recipients, care recipients. Caregiving is perceived as a duty. Sometimes, when we talk about caregiver burden or caregiver stress, sometimes people don't understand it as a burden because it is a norm to be taking care of older, not only parents, other older members of the family in a joint or extended family. It is thought of as a duty of the younger generation to take care of the older members of the family. So, this is not considered as a burden. It is usually accepted as a duty. But nonetheless, this does cause some stress in the day-to-day activities which have to be accepted. Then lastly, there's a lack of awareness. There is a lack of awareness of condition like dementia and a lot of stigma attached to mental conditions in India. Because of lack of awareness, there is hindrance in the caregiving process. So, what are the responsibilities of the and challenges that the families face? So, with passage of time, the joint family or the extended family has now changed into has given rise to nuclear families with younger adults moving in search of jobs, and now there are more nuclear families with middle-aged people taking care of their parents, older parents, and also are responsible for bringing up children in together with their own professional duties. So we call these middle-aged people the sandwich generation, who are taking care of parents and children, and multitasking and taking care of their own professional duties. So this family dynamics has changed, and before they would get help from different family members in a multi-generation family. Now it is the middle-aged people who take care of all these responsibilities in a family. There is also a role of overload, mainly women. The role of women has changed a lot over the ages. Before, they would be taking care of the home and hearth, whereas the men folk would go out for work. With the changing roles, women are taking up more professional roles, but they're balancing multiple roles at home also. So this puts a burden on them. They are multitasking. And in Indian families, sometimes women don't have an autonomy or taking decisions, and they sometimes feel unappreciated of the work that they are doing. This puts a emotional stress on them. Caregiving is an engaging and exhausting activity, and more so in cases like chronic conditions like dementia and cognitive impairment in older adults, which puts an emotional toll and physically also very demanding. Loss of job to fulfill caregiving roles can cause financial strain on the caregiver. Social isolation. Because of the caregiving roles, the caregiver has fewer opportunities for social interactions, which is also exacerbated by the stigma associated with certain recipients' conditions, mainly dementia or mental conditions. Now, existing evidence. We have very few longitudinal or prospective cohort studies, evidence from these studies. We have some studies, some evidence, mostly from the WHO SAGE publications, which have shown that informal caregiving is a norm in India. Informal caregiving, where the caregivers are mainly family members who are not trained in caregiving. They have no formal training in caregiving. That is mostly seen in India, and that is much more in comparison to other low and middle income countries. It has been seen that more than 40 hours per week of informal caregiving is associated with higher likelihood of depressive symptoms. This in the LASI study, this has been published in the from the report of the LASI study. The 10/66 reports that caregivers of older adults with dementia have a likelihood of reduced working hours and express increased healthcare costs relative to caregivers of adults who are without dementia. So these are some of the empirical evidence, existing evidence, but there are limitations because most of the studies done till now have been done on smaller population samples. They have been done on geographically limited population, and they are mostly convenience samples. There are very few progressive, prospective large cohort studies of caregiving in India. And there is also lack of multi-level studies of caregiver health data linking care recipient health and cognition data, which has been taken care of in the LASI-DAD caregiver study. And on with this introduction, I will now hand it over to Marco. Dr. Marco Angrisani will discuss about the empirical results that we have found in our study and which has been recently published in the Dementia and Alzheimer's and Dementia Journal. Thank you very much. If there are any questions, I'll be happy to take the questions. I'll stop share now.
Can I move on, or do we want to address questions first?
You're in presentation mode, speaker mode, Marco.
Oh, let me. Let me fix this. Sorry about that. Do you know how to get out of this? No.
I think if you start from the beginning and then it'll be in full screen and then you can scroll to the current slide.
So here and then
in the upper left corner. Yeah.
Oh, here?
Beginning. Yeah.
I don't understand why I'm still in this mode.
1 second. If you hit hide presenter view.
Where? Sorry? This one?
It says to switch the display settings in the top left.
Yes.
Yes, yeah.
This one?
Yes.
Okay.
Yep, that's it. Thanks,
Sorry
Emma.
about that. Okay. So let me start from where Dr. Joida left. She mentioned the limitations of existing studies about caregiving in India, specifically caregiving related to dementia or cognitive impairment. And we try to bridge these gaps with a new data collection effort that we carried out in the second wave of the LASI-DAD study, introducing the caregiving module within the informant questionnaire. The idea is to prospectively collect data on informants, and we want to do that by eliciting their caregiving responsibilities relative to the LASI-DAD respondent, who will be the care recipient, and also try to understand the consequences of caregiving, especially when it comes to taking care of a person with cognitive impairment. We think that this is a very important innovation in this field because this is going to represent the very first linked nationally representative data set in India, where we have dyad observations. On one hand, we have extremely comprehensive detailed information about the care recipient, the LASI-DAD respondent, and on the other hand, we have information about informants and potential caregivers of this person. With this information, we can tackle questions about caregiving in India and the consequences of caregiving for people with cognitive impairment. Joita has mentioned all the information that we already collected through the informant questionnaire. With the caregiving module, we start with a screening question that reads as follows. Are you primarily responsible for assisting the LASI-DAD respondent with their daily activities, or is there someone else in the home who takes on the primary caregiving role? And as you can see, the answer options go from I am the primary caregiver to I share responsibility with other family members, or someone else in the home is the primary caregiver, or the respondent primarily cares for themselves. These answer options delineate a clear gradient in the level of caregiving responsibility, with the top option representing the highest level of involvement and the bottom one representing basically the lowest level of involvement, given that the respondent is primarily caring for themselves or can be considered independent. Indeed, we are going to consider informants who say that their respondent is independent as non-caregivers. Now, the beauty of the design, or at least I think the beauty of the design of this questionnaire is that we have information about caregivers and non-caregivers. So informants can be caregivers or non-caregivers, but we want to study how the cognitive impairment of the respondent affects the well-being of family members, including both informants who are involved in taking care of the respondents and those who are not. And also we go in depth when we have a caregiver asking about the intensity of caregiving, for instance, for how long they're providing care, how many hours a day, how many people they care for, because as Joita mentioned, sometimes we have situations where just one person takes care of an older adult as well as kids in the house. And also we elicit information about rewards from caregiving, which is important because we don't want to focus exclusively on potential burden that comes from caregiving. Now, when we performed this study, the study that was published in Alzheimer's Dementia, our goal, as I will mention in a second, was to compare well-being between caregivers and non-caregivers and try to understand the moderating role of different levels of responsibility in this kind of relationship, and particularly focusing on what it takes to take care of a person with cognitive impairment. We focused on 4 outcomes, which were elicited for both informants that were caregivers and informants that were not caregivers. These are current perceived stress, mental health as measured by the validated CESD scale. We had 2 questions eliciting feelings of calm, peace, and cheerfulness, which we call positive affect. And then 3 questions about feelings of inner peace, spirituality, and thankfulness, which we put together into a spirituality index. These will be the 4 well-being outcomes that we will analyze in our study. Now, the 2 research questions that we posed are based on these 2 hypotheses, which we think, given the data at our disposal, can be reliably tested for the first time in India. The first hypothesis is that cognitive impairment of care recipients, the LASI-DAD respondent, is associated with a higher level of stress and lower levels of well-being among informants, who, as we will see in a second, are often co-residing family members. The next hypothesis is looking at the moderating effect of caregiving role. Particularly, we hypothesize that the adverse effect of respondents' cognitive impairment on informants' outcomes is more pronounced the more caregiving responsibilities the informants have. Now, before I show you the results, let me talk a little bit about the sample we have and the characteristics of this sample. As mentioned, this caregiving module was introduced only in wave 2, so we are only focusing on wave 2 sample. For this analysis, we need information on both sides, the care recipients, the LASI-DAD respondent, and of course, the informant. So after excluding a few with missing information on either side, we have 4,200 informants in our in our sample. The composition of this sample is as follows. Probably not surprisingly, especially after the introduction by Dr. Joida, you'll see here that for the most part, 61%, these informants are female. We have a broad range of ages, although given that these are informants of older adults, they tend to be younger. And as you can see here, the two largest groups are the 30-39 and the 40-49. Because of the younger cohorts, we also see that for the most part, 46% of this sample have secondary or higher education. This is very different from the education composition of the LASI-DAD sample, where 50% or a little bit more have no education at all. Now, when it comes to the relationship between the informant and the respondent, again, echoing what Joita described as the cultural framework we are operating within, you see that 28% of informants are daughter-in-law, and then we have 23% sons and 24% spouses or partners. Also, again, based on the cultural framework described by Joita, most of the informants, 83%, co-reside with the respondent. And 14% have daily contacts, even if they don't live together. And only a minority, around 4%, have contact several times a week or less. When it comes to the role that informants have in terms of taking care of the respondent, we see that 37% identify themselves as primary caretakers. We have 24% shared caretakers. Only a minority, 6%, are non-primary caretakers, meaning that they provide occasional help, but they are not the major providers. And finally, we have 1/3 of the sample who says that the respondent is independent, so we are going to consider these people as no caretakers. Now, in order to tackle question 2, where again, we want to see how the potential adverse effect of cognitive impairment of the respondent on the informant well-being is affected by the caregiving role that the informant has, we need variation in the respondent's condition within the 4 groups defined by the caretaking role. In other words, we don't want all the respondents with probable dementia to be within the groups of primary caretakers, because otherwise this analysis wouldn't work. This graph shows you the distribution of the total cognition score for the 4 caretaking role groups that we identified in our questionnaire. As you can see, and not surprisingly, the black distribution corresponding to the non-caretakers is shifted to the right, meaning respondents within the group of informants who say that the respondent is mainly independent perform better in terms of cognitive scores. However, this distribution overlaps with the other distributions, meaning that there is enough variation, and explicitly there is a good range of very low values in cognitive scores, even among these respondents, meaning that even among this group, the possibility of cognitive impairment is still high. And indeed, we see this when we look at the CDR score of respondents. The CDR is, as you have seen in previous seminars, is basically a score that is assigned to each LASI-DAD respondent by doctors. And a CDR greater than 0 indicates probable dementia. The proportion of respondents with a CDR greater than 0 is 52% among primary caretakers, is 56% among shared caretakers, is 54% among non-primary, and is 40% among non-caretakers. So it's definitely lower, but not 0. A similar story emerges if you look at difficulties with activities of daily living. In general, we see that within the group of primary and shared caretakers, the respondents have a higher number of difficulties with ADLs. But of course, within the group of known caretakers, you see fewer difficulties, especially when it comes to bathing and eating, which are two of the most important and basic activities on a daily basis. These are the 4 outcomes of interest we will be looking at. The stress index that ranges from 0 to 16, higher values indicate higher levels of stress. The mean is 6.13. The mental health index goes between 0 and 20. Again, higher values indicate higher levels of poor mental health. As you can see, even though the theoretical lowest value is 0, the distribution starts from a value of 5. And the median in this case, the mean in this case is 10.14. Then we have 2 indices looking at positive outcomes, particularly positive affect, an index going from 0 to 8 with a mean of 4.83, and then the spirituality index that goes from 0 to 12 with a mean of 7.64. Now, this is how we tackle our research questions, also based on some inputs we got from our referees. So first of all, we create indicators equal to 1 if the informant indices that I just showed you is above the sample median. So these indicators will reflect high levels of the 4 outcomes of interest. Then we classify the respondent of each informant based on the CDR score available in the LASI-DAD. Particularly, we are going to have the no dementia respondent, those with a CDR equal to 0. This is going to be our reference group. Then we are going to have respondents with questionable dementia, CDR equal to 2.5. Respondents with mild or moderate cognitive impairment, CDR equal to 1 or 2. In wave 2 of LASI, there were no respondents with a CDR equal to 3, indicating severe cognitive impairment. With these 2 variables, then, we estimate a logit regression, where basically we regress the indicator that the informant index is above the sample median on the CDR of the respondent. Basically, with this framework, we are going to study how the probability of having high levels of stress, high levels of poor mental health, high levels of positive affect and spirituality is different between informants of dementia-free respondent and informants of respondent with probable dementia. In all this regression, we control for both informant and respondent's characteristics, including the respondent's ADLs, which we take from the LASI-DAD questionnaire. These are the results. I'm showing you in just graphs, and let me describe them. So here, let's look at the first figure in the top left. This is referring to the probability that the informant reports a high level of stress. In this case, you see that compared to informants of dementia-free respondent, those with respondents that have questionable dementia have a higher likelihood of reporting high level of stress by 9 percentage points. Among those with a respondent that has mild or moderate cognitive impairment, this likelihood increases by 16 percentage points. Importantly, the difference between the 9 and the 16 percentage points here is statistically significant, meaning that this gradient that you observe, so a decrease in the level of well-being of the informant as the level of cognitive impairment of the respondent increases is statistically meaningful. We see a similar pattern for the probability of reporting high levels of poor mental health. Again, compared to dementia-free respondents, those informants of respondents with questionable dementia have a higher likelihood of reporting high levels of poor mental health by 9 percentage points. And those with a respondent with mild or moderate cognitive impairment exhibit a higher likelihood of reporting poor mental health by 17 percentage points. When it comes to positive affect and spirituality, we see, of course, the opposite effect. In this case, an effect that is negative means that the likelihood of having high levels of positive affect and high levels of spirituality decreases with the cognitive impairment of the respondent, which we also see clearly in these two figures. So overall, just to summarize, the hypothesis that informants of respondents with cognitive impairment exhibit lower levels of well-being is fully supported by the data. Now, let's tackle the second question, which is possible given this dyad framework that we have, leveraging both information on the respondent and on the informant. In this case, we want to explore heterogeneous effects of the respondent's cognitive impairment across informants' caretaking roles. In other words, we want to see whether the adverse effect of the respondent's cognitive impairment, which we just observed, are going to be different depending on the informant's caretaking roles. The hypothesis that informants who have a higher level of caretaking responsibility would have also worse consequences. Is that true? Is this supported by the data? In order to answer this question, and in particular to also increase power, we are going to create an indicator for probable dementia of the respondent, which is equivalent to a CDR greater than 0. And then we are going to estimate the same logit regressions as before, but this time we're going to introduce an interaction between the respondent probable cognitive impairment indicator and the informant's caregiving role indicators. Then, based on these estimated logit coefficients, we compute the marginal effects of the respondent's probable dementia on the probability that informants report high levels of stress, poor mental health, positive affect, and spirituality across the 4 possible caregiving roles. If these effects are homogeneous, it means that there is no moderating effect of caretaking role. If they vary, it means that there is such moderating role. Let's look at the results. So as you can see immediately in the top left figure, there is a pretty homogeneous effect on stress of respondents' probable dementia. Indeed, the highest effect is observed for primary caretakers. For them, the likelihood of reporting high level of stress when the respondent has dementia increases by 10 percentage points. But this is not different from the probability or the increase in the probability reported by non-caretakers, which is 9 percentage points. So we don't see heterogeneous effect in this dimension. We do see heterogeneous effects when we look at the probability of reporting poor mental health. In particular, compared to non-caretakers, primary and non-primary caretakers are those who suffer the worst consequences. In particular, for primary caretakers, the increase in the probability of reporting high levels of poor mental health is 13 percentage points. For non-primary caretakers is 20 percentage points. A similar pattern emerges when we look at the probability of reporting high levels of positive affect and high levels of spirituality. Again, for non-caretakers, there are basically no significant effects, both in terms of size and in terms of statistical significance. But when we look at the effect that we see for primary and non-primary caretakers, we see significant and pretty large effects. So overall, the hypothesis that the adverse effect of respondents' cognitive impairment on informants increases with caregiving responsibility is partially supported by the data. This is because we don't see this across the boards or for all domains. And in particular, we also see that compared to non-caregivers, not only the primary caretakers who have the highest level caretaking responsibility suffer the consequences of caretaking, but also non-primary caregivers show significant declines in well-being when the respondent has probable dementia. So these results that non-primary caretakers may actually feel the consequences of taking care of a person with probable dementia, even if they're not particularly involved, was particularly intriguing. So we delved a little bit more into the mechanisms that probably produce this result. And we looked at the composition of non-primary caretakers. In particular, we see that non-primary caretakers, relative to the other groups, differ in two dimensions. First of all, they are more likely to have other kind of relationships with the respondent. In particular, 60% of them are actually grandchildren, 20% are other relatives, and 12% are siblings. So they are not as related to the respondent or the care recipient as the other groups are, because in the other groups, the caregiver is more likely to be either the spouse or partner, son or daughter-in-law. Second, and this is also a very important aspect to underscore, non-primary caretakers are less likely to be living with the respondent or with the care recipient. The proportion of people living with a respondent is only 62% among non-primary caretakers versus 85, 86 within all the other groups. So what's the result of this? Well, if you look at non-primary caregivers co-residing with the respondent, given their younger age, they could be not very well equipped to deal with the challenges presented by dementia caregiving. And that's the likely that could be a reason why they also suffer the consequences of taking care of the respondent, even if they're not the primary caretaker. If they don't live with the respondent, then they face other kind of challenges. They may have to travel to get to the respondent. They may face other logistical challenges, and they may also feel the emotional toll of being distant from the respondent, and therefore sort of a lack of control when it comes to implementing or performing caregiving tasks. So overall, let me conclude and then take questions. We find that assisting a person with dementia extends far beyond providing physical support and significantly affects the emotional and spiritual well-being of family members. Notice that I'm focusing here on family members on purpose because I want to emphasize that our results underscore that in the contextual context of India, where a large household may take care of older adults, all family members seem to be affected by the cognitive impairment of the care recipient. The findings underscore the need for greater support for caregivers in terms of formal care infrastructure and mental health resources. Another thing that comes out of our analysis, especially when we look at non-primary caregivers and the adverse consequences that the respondents' cognitive impairment may have for them, is that joint family structure can ease caregiving through shared duties, but may also create conflicts, especially when caregiving roles are gendered, as Joita mentioned before, and add strain on household members who, even though they're not directly involved or only marginally involved, may not be well equipped for dementia-related challenges. Finally, I want to emphasize that this is, as I mentioned in the introduction, the first kind of study in India where we have a double or multi-level information on the care recipient side and on the caregiver side. So this study enhances our understanding of caregiving in low and middle income countries by situating findings in the Indian cultural context. But importantly, it really sets the stage for future research in these environments using representative caregiver and care recipient data, which are difficult to find in low and middle income countries and also in India, with the LASI-DAD being an exception. Thank you very much, and I'm happy to answer questions. So the first question is if there is an effect of a rural versus urban setting. I didn't present the results on this, but they are in the paper. I'm looking at the table right now. We only find a slight increase in the probability of reporting high level of stress for informants in rural settings, and it's only significant at the 10% level. So I would say that we don't find too much of a difference between households in rural and urban settings when it comes to reporting the outcomes we are interested in. Second question is the CDR score available for individual respondents in the phase 1 LASI-DAD data set? I mean, in wave 1, yes. The CDR score is also available for respondents in wave 1, not to the same extent. I mean, for wave 2, basically the entire sample was provided CDR score. In wave 1, it was only, I believe, 2/3 of the sample, but we do have it. Minky says, thank you, Minky. The findings about the non-primary caregivers are very interesting. Have studies in other countries come up with similar findings? Not to my knowledge. And I believe this is a unique feature of the Indian study, given the cultural context and the type of arrangements that lead to caregiving in India. Do we see effect differing across caste categories? Again, I'm going to look at the results. No, we don't see effects across caste. I didn't mention this, but this could be interesting for everybody. I focused on the results that basically answer the 2 research questions that we posed. But of course, in the analysis, we have both individual characteristics on the respondent side and on the informant side. A couple of patterns emerge. The first one is that compared to informants who are spouses or partners of the care recipient, sons and daughters-in-law have lower levels of well-being. And the other pattern that is important is that people who don't co-reside with the respondent but have daily contact also exhibit lower levels of well-being. Again, this could be because they have to travel to that place, or they face other kind of logistical challenges that may affect their day-to-day life, especially if they have to manage a job and also their caregiving responsibility. Did you have information on the states of survey response? Yes. And we no, we don't. We do have information. We don't have state fixed effects in our regressions. But we know where we know the states where the household is. Was the stress level in informant related to formal education levels? Can answer this. Yes. Compared to informants with no schooling, informants with secondary or higher education exhibit lower levels of stress, lower levels of poor mental health, higher levels of positive affect, and higher levels of spirituality. So there seems to be a little bit of a gradient in terms of education, with informants of higher social economic status exhibiting better outcomes.
All right. Thank you very much, Marco and Joyita. It's great to have you share the findings with the larger audience here. Greatly appreciate that. Sarah, do you like to make an announcement for our next webinar?
Yes. So our next webinar will be in September. We haven't finalized the date yet, but it will likely be early in the month. And Dr. Perry Hu and Anushka will be talking about biomarkers in LASI-DAD, and information on the webinar, as well as the recording and slides from today's webinar, will be on our website. I can put it in the chat here. And you can also find more information and documentation about the informant interview and other parts of the LASI-DAD protocol on our website, as well as instructions for access to data.
Great. Thank you very much, Sarah. Thank you, everyone, for coming for today's seminar. Have a good night and good day.
Thank you.
Thank you.